We wanted to give a lot of time for this session because it's particularly important that we give the attention and time to our patient partners, and and Chris is here representing that community. I have to say, he also has the best sweatshirt that I've seen. So afterwards, I'm going to ask him where he got it. So Christopher has been living with long COVID since his first infection in July 2022. He knew something was wrong after a training run left him unusually out of breath and feeling odd body pains. And after multiple symptoms and searches for answers in the healthcare system that would lead to a number of ER visits, trying to find the answers in the US and being very expansive in his search, and sounds like it's a story that I think resonates with a lot of our patient partners. He was unable to work full-time due to the long COVID symptoms. Now, Christopher's former career was a research project manager within the healthcare university setting at UBC, with a focus on health inequalities. And he moved on to work in Switzerland and also Germany in an international high school setting, coaching athletics and cross-country running. And he returned to Canada just before the pandemic started. Before getting long COVID, Christopher was an avid endurance athlete, participating in numerous marathons, triathlons, and long-distance cycling races. He has participated in age group categories for World Championship in triathlons and decathlon. Christopher is using his sociology research background and social work education within the Long COVID Web Patient Council. So without further ado, I'd love to invite Chris to come up here and give us his presentation. Thanks.
Hello, everybody. Just I guess if people are wondering, there is a great group called Berlin Buyers Club, which is an online group of women in Berlin who decided that they're artists and long COVID people, and they have actually designed a lot of these sweatshirts. So if you go online and just search out Berlin Buyers Club, you'll find lots of different designs as well. So
for the myopic people who can't see,
Oh.
Can you tell them what it says?
Yes. Can you read that? Long COVID is chronic. Masking is iconic. Thank you. So you heard a little bit about me, and I think what I want to do a little bit as well is, go on a little bit of why we're here. So I want to talk after all that a little bit. In May, I was selected to participate in the Long COVID Web Patient Advisory Council. So, and for me, it was very important. It provided me with a purpose at a time when I really needed one, quite honestly. And I'm able to use my sociology research background and my master's of social work education to provide help with that community. What I want to go into a little bit here, because we have a bit of a different format here, because really it's not going to be about me, it's going to be about all the other people that want to make comments and sort of share some of their stories. So the idea of this session was in response to last year's symposium feedback. Patients felt that they were not being heard at last year's conference. So the purpose of this session is to attempt to address this feedback by using the title above, as you see, Medical and Social Stigma, Living in an Ableist World, as sort of an opening for discussion and comments. There we go, okay. And first and secondly, what I would like to do now is invite people to comment online under the chats using what we have right here in terms of all that. And once again, remember that the participation will be in comment and discussion, not in question and answer. So I probably, oh, there we go. There we go, yes. And we want to try and invite that this be sort of a connection point, so in the room. So I think one of our advisors in the patient group wanted to call it the living room. So, and make it sort of just a welcoming place for all of you to give your comments and feedback. And I also want to highlight again as well that it's going to be about experiences of people with long COVID people, but I also want to add caregivers. They don't often get mentioned. And I now know after looking through a lot of messages already that sometimes those are dual roles. So as I've heard today already, some people are caregivers on top of having long COVID themselves. So that is very, very difficult indeed. So before we, whoops, is I want to talk a little bit about what the Long COVID Patient Advisor Council does, which you probably heard a little bit already from Angela. So we're a council of about 9 to 12 people who are lived experience and or caregivers from diverse backgrounds. You probably have had a chance to meet quite a few of us so far in the audience. So, you know, we're always in the mood to talk, okay? We work together with researchers, clinicians, physicians, and other long COVID web members to try to advance research in long COVID. We help out with a determination of patient-oriented research priorities, the process of patient engagement in research projects, in both tools and resources, okay? And we'll mention a little bit about some resources at the bottom. So we'll start get going here. So when our group subcommittee got together and the larger committee, we wanted to try to figure out how we wanted to frame this session. And what we thought is we will eventually, after many, many subcommittee meetings, try to figure out how we wanted to use this as well as we possibly could. We brought in stigma and ableism. And what I've done here is I sort of provided just words to sort of help generate the discussion and the feedback. So as you can see, you know, stigma is intersected with age, either children, adults, gender, ethnicity. I like to use that word intersected or intersectionality because a lot of times people can be multiple different things at the same time. So you could be a person of color who has long COVID, who is also in the LGBTQ community. So there's lots of different levels that can happen in terms of stigma with those different sort of identities, okay? Obviously, I got up here as well. We probably had a little bit already. Medical stigma, gaslighting, disability claims, etc. Other topics would be social stigma, gaslighting, mask wearing, invisible illness, disability benefits, and finally, I talked maybe a little bit as a point of conversation, risk of reinfection and work accommodations as well. And I originally put risk or sort of fear of reinfection, but that's not really a fear because it's actually a reality. So we can definitely look at risk of reinfection. So I invite you to sort of get online now, and with those sort of words that we've brought in and on there, you can put in a chat various different situations that we would like to talk about. The one thing I will mention too as well is, of course, this is being filmed, so be careful with personal markers if you don't want to be identified, okay? So we never know what kind of situations some people are in. So I want to go towards that, okay? Maybe to sort of kick it off, I've been quite busy as well, actually going through lots of comments and things like this. And what I'm just going to do is use one that I found today in a different chat from yesterday. With one person, I won't use the name, and it's got directly to do about mask wearing. So I feel stigmatized and isolated when I'm wearing a mask. It is an external marker of my diversion from the herd. I do think I bring some of that on myself because I hate to be different. It's a strong evolutionary pull to belong. And I'm just going to change to the mic here. Sorry, I don't know how to turn that on. Okay, it's on? Thank you. I just wanted to use that as a sort of a starter as well. So, what do we have so far out there, Susan? Is there any messages coming through yet as a direction?
There are some.
Because I'm here as a facilitator. It's all those people out on the community. It's up to you.
There are some messages in the Q&A, and they don't have to be questions. They can be comments, which is fine. We sort of decided we'd leave the chat just for the chat between different people participating. So if you'd like to make a comment that I'll bring up here to deposit in the conversation, please put it in the Q&A. So there is a comment about how can we work to make society more accessible to us, and by extension, this would help all people with disabilities. Mm-hmm. So are there ideas about how to make society more accessible?
Mm-hmm. Actually, I do remember that one, and I did like it, and maybe this might help generate even more discussion, because my personal opinion on this a little bit is, I'm going to take a little word out of the LGBTQ community, and that's the word ally. And I'll say the capital A ally, because technically what normally happens with advocacy is the people who are in the middle are the one advocating. I myself am in long COVID web, and it's a lot of work. We don't have the spoons or the energy to do the advocating a lot of the times. And I will add, neither do our caregivers. So I've had this conversation with my wife, who is the caregiver for me, who has to do everything pretty much. So I'm very happy for the stuff that she does for me every day to sort of feel normal in some situations. But, outside of that, we're too tired to be able to do that. So, I invite Canadian senators, for instance, who should be picking up the torch, so to speak, on these sort of situations, because obviously that's also got to do with a lot of social policy and things of that sort. So I don't know what people think of this comment back, but I'm more welcome to hear some comments even in the audience if they wish. There we go. Yes, sorry, go ahead. I'm sorry.
I hope it's okay if I transition to a little bit of a different topic, but maybe looking at your screen is just worth the discussion. I'm a medical doctor, and I'm honestly a little bit embarrassed for our profession, little bits in quotations. I just even think of the comment earlier today by one of the speakers that there's no room in the curriculum to talk about COVID or long COVID. And I think about the fact that in the last 12 months, it was in Alberta, the 7th leading cause of death. And as we know, a leading cause of disability, which is affecting all sectors of society. I ran into a medical student a couple weeks ago, and she was telling me that they're not really talking about COVID except in the past tense. They're not being taught about it being a major killer. They're not being taught how to prevent it from them getting sick or from making other people sick. And I think this attempt to disappear COVID from society, from our political leaders, has infected our education system. And I just want to say to those people suffering from long COVID that, even though the education system, the medical system is not seeing you, I see you, and I think we need to change the fundamental knowledge of our providers in order to change the interaction. And in some ways, there's this tension in me to say that, our doctors have an obligation to self-educate because this is such a huge issue. But at the same time, like all members of society, we need to kind of be spoon-fed this stuff by our leaders, by our educators, because, a lot of people don't have time to go looking through Twitter or the interweb to find the long COVID web where there's, reliable information. So we need our postgraduate medical education, our undergraduate medical education, our resident educators to include this, as this is a huge part of our world now, whether we like it or not. So.
Yeah, you bring up obviously a lot
Yeah.
of good points because.
Unfortunately, there's a lot there.
We all as patients can think of all kinds of instances which have already been documented in multiple places. And I can comment myself, like, I literally lost my GP 2 weeks before I got infected. So I was just trying to figure out the system with no doctor, which is one of the reasons why I ended up in ER everywhere. But when I ended up getting a GP, she's a placeholder, so she doesn't want to learn. And I was the one that was feeding her evidence-based materials. So sometimes some doctors, actually I've heard some stories that works really well. Other doctors are, especially GPs as we know, are probably too busy to be figuring that stuff out. But there's a lot to unpack there in terms of education.
Just for context, diabetes is number 7 along with COVID. Can you imagine a world where doctors aren't taught about diabetes? That'd be insane, right?
Actually, and I thank you for pointing that out because I do use that. If you know somebody with diabetes, you probably know somebody with long COVID. So good point. Thank you. Susan, is there more? Yeah.
Well, I think there's another point here that's related to the educational sort of mandate, which is around insurers and being invisible to insurers. So are there strategies or has there been any success in terms of bringing insurers into the fold?
Can you imagine if that was the case, that there was something? They would be in a lot of trouble, wouldn't they? So in terms of insurers, I think that's, and I think everyone else, with the same situation, that to have a diagnostic tool to say that you have long COVID finally is some kind of a biomarker is certainly going to help a lot in that. So I will use, and this is on the other side in terms of insurers, and I would say disability claims as well. I will just do a shout out that I'm, now in a program in British Columbia with a couple of doctors, Dr. Jane McKay, who's here actually, and Dr. Rick Arsenal, and they specialize in post syndrome chronic illnesses. And I can honestly say a lot of their work is disability claims. So that is a lot of work for a medical doctor to do, to try to provide that kind of work beyond just the day-to-day sort of doctor sort of situations. So I wanted to highlight that because I know it's not exactly the same as being an insurer, but we're not going to probably not going to get the credibility until we get the definition.
Just might add to that, in long COVID web, we've had a couple of clinicians now offer their letters of disability applicant, to support the application for disability or for work accommodations, which we're going to actually sort of anonymize and post as a resource on Long COVID Web, so that might be useful to others.
Yeah,
Angela?
So it is hard work trying to make physicians aware, make insurance companies aware. I think it's harder with insurance companies because they have shareholders and other things, so their priorities are a little bit different. But I can say that actually with Long COVID Web, we try to work with the Canadian Health and Life Insurance Association, and we've done several presentations at their annual meeting. And so it's obviously we need to do more. There's no question. Just the number of letters that people ask for as well. It's anyone who's interested in working in this area, please come and chat with us, Susan or myself, because we would love to have a team that can work with the Canadian Health and Life Insurance Association. They were actually aware, they were on board early on, but things haven't moved fast enough, right? So like we have people who lost jobs and lost their insurance and everything else as well. So it's not fast enough. And I also want to make a comment about sort of biomarkers. We have actually a lot of clinical conditions without biomarkers. Migraine is a good example. I think we need to teach other colleagues, physicians, to diagnose based on clinical presentation. Because I'm a bit concerned about biomarkers, like I'm all for biomarkers. I actually attended that session earlier rather than in here because I want to learn as well. But my concern, because of the heterogeneity of the population, if we have a biomarker that says, oh, someone has long COVID and these other people who has long COVID does not have long COVID, we get into another sort of, can of worms.
Thank you, Dr. Chen. Yeah, I agree. There's, the inclusion-exclusion sort of situation that can be not useful sometimes. So, thank you. Anyone else? We have some more chats that seem to be coming
We have
up.
a lot of
Susan?
stories about individual experiences of gaslighting and of the invisibility and the dismissiveness. So
cool.
I think it's a very common, unfortunately, experience.
Yeah. Can we read a few of those out? I think that's important because one of the things that's nice about this is that, we do have doctors and clinicians in the room. So, I mean, we're probably talking to the choir, but that's still okay. At least this one is being recorded. So, Susan?
Yeah. My GP has generally been supportive and believes my symptoms, however, still holds onto certain misconceptions, such as that my symptoms are due to deconditioning. He also didn't fully understand what POTS is and questioned my POTS diagnosis provided by an internal medicine specialist. Clearly, further education of healthcare providers on long COVID is needed. If we manage to have doctors to acknowledge and diagnose, the insurers will not accept it. Their medical advisors that have never met us, never spoke with us, have no history of us, make a decision that we are not ill, and then we have to fight for benefits, which adds so much to our symptoms. I had to change GPs twice in order to find a doctor who believed that my illness was real and not just a result of anxiety. It's very difficult to find doctors who even believe you, let alone know anything about how to treat long COVID. Specialists have been unhelpful too. I had just one tell me it's all deconditioning and I need to exercise more, and another who told me that all my symptoms were stress related and to cure them I should take a nice walk in the sunshine.
That is one that is very well descripted. So thank you. That's very good. We have someone who would like to make a comment, and this is Dr. Jane McKay. Thank you.
Chris, thanks so much for mentioning my name. It's not that I need to be recognized, but I want the entire medical community to recognize the need to accept illnesses that are so prevalent. It's unbelievable. Anyway, the table convinced me to stand up. And so with regards to disability, so the disability is a really tricky area, and it's really important to find someone to be your advocate. And each provincial organization has advocacy groups, but you have to bring it to a clinician to write the forms in a way that will be successful for you. And that has to be, so an anecdote, the letter for appeal that I write, say, for Canada Life, is now being rejected because they've seen it before and they don't feel it's valid. So that's the speed at which the insurance companies are making differences. So I just was a bit concerned about the idea of putting a standard letter out there. But maybe there's a way as a community of physicians and patient partners that we work together to try to break down this incredible barrier and discrimination from financial.
Thank you. Thank you very much for the comments. Appreciate it. And thank you for coming up and speaking. So, and you know, that this, you know, I think I'm going to use another term because this is what we're looking at right now is poverty, right? So we haven't really used that word too much. I haven't been to all the sessions, but you know, I'm a person of privilege, so I'm very lucky. So that I'm at an age where, you know, we've had a little bit of money schooled away before this happened. So, but as we've heard already earlier before, what about the 20-year-old? What about the family of four where one person is not working? What is, you know, those kind of situations. So, yes, do we have another comment? Yeah.
Yeah, I'm curious about the caretaker and the patient, I guess you could say, because I'm one of them. I'm a mental health provider. I don't actually work in Canada because I'm not allowed to, so I actually work in the United States, which is interesting. Because the psychology board here has made it extremely difficult for me to transfer my credentials. So I'm kind of stuck in two spots. So while I'm suffering with long COVID, brain fog, everything, I'm going back to school, trying to learn at the same time while I'm providing care for people in the US, which is such a complicated thing. But I'm curious because I haven't really heard much about teaching psychologists, teaching the psychology you know, faculty that long COVID is real. It creates a whole different cluster of symptoms that is different from any other disability, any other kind of learning disability. It's so different. And I haven't really heard much about teaching psychologists who are then sending out, you know, in the psychology faculty that are sending people out there that are dismissing symptoms, because I've actually found that from a clinic where I worked. I had to leave simply because they just wouldn't accept the fact that I was not able to do the same things that I was before. Luckily, my mental health is okay. I'm saying these things that is risk to my own practice in general, but it's kind of ironic that the profession that I'm in is actually the one that is the least compassionate, least open to discussing different issues, different things that are coming up, and honestly not really having any flexibility around helping people be successful. I've been very lucky in that I've found practitioners here in Edmonton that have been very helpful. But honestly, I'm relying on my colleagues in the United States who knew me before. And they constantly are propping me up to say, keep going. Because the other part of it is that there's no support for self-employed people. I have nothing really. So I have to rely on my US income, which luckily I can do a lot of flexibility, but now if I move into any kind of clinical space here, I'm going to have to be subject to, again, all of these things that I keep hearing of. Oh, you're malingering, you're making that up, just go outside, just do these things that typically we would say as clinicians, but at least now that I know what I've gone through, I can have a lot more compassion and also try to educate others of these things don't always work. Do not tell people just go outside when you can't even think about lifting your head off of the pillow, really. So trying to be more creative around how do we help the mental health of our long COVID people.
Thank you for that. And it's, there's a lot to unpack there too as well, because a lot of patients, you know, get a little bit itchy when it comes to the mental health because, you know, they've already been told that it's in their head. And we all know, I definitely know, like, you know, for me, it was definitely downstream. So, you know, I've had to take care of my own personal mental health a lot through this, because I'll reiterate what somebody earlier in one of the other chats said, you know, maybe it's better not to ask what you've lost, but what do you have left? Because, you know, we don't have a lot left. Our worlds are just so small. So in terms of friends being gone and all that, and that's all wrapped up within mental health. So there's no doubt about that. And, you know, I think there's, you know, I will say, like, my wife is actually a counseling therapist. So that's her role, and she's gone into a private practice within the last year and a bit. And, you know, she's trying to get other people to, you know, there's a list in BC about sort of, you know, COVID conscious type of therapists. But, you know, I would probably have to find that out. I don't know for sure, but I don't know if there's actually any standards with that in general. But maybe just mental health people that have a specialty in chronic illness in itself, I would say at the moment would probably be useful. So, thank you. Yeah. Next person. Is that, yes, next person? Yes, please go ahead.
Hi, everyone. I'm a parent of a teen daughter who has been living with long COVID for about 4 years. And just to give context, I took the opportunity to create a care team just for her so we could troubleshoot some of her symptoms over the course of 2 years. And one of the things I want to mention is the disability piece on the pediatric side. And so it took me about 2 years to gain the strength to apply for disability, because out of the 4 doctors, there was 1 doctor willing to sign off on the medical practitioner form in Alberta, and I'm based in Calgary. And I'll tell you this, that 3 of the doctors, you know, checked her out, everything was normal. And one of them filled the form out, but was not willing to sign it because they didn't believe that there was such a thing as long COVID. So the doctor that, she was a pediatric respirologist, she was willing to sign it because she was seeing a minimum of 3 children with long COVID every week in Calgary, because that's where she was getting referred to. So I just want to say to the parents with children that I really do encourage you to apply for disability, but I think the biggest hindrance right now is, again, just going back to the fact that your pediatrician does not believe you And if they don't believe you, don't stop. Try and find a different specialist who will believe you. And, you know, I think, I don't know if that's helpful, but I wanted to share that with the community. Thank you.
Thank you so much for sharing that, because obviously this is going to be a much bigger deal, so in the near future. So as we know, there is such thing as long COVID in kids, and you know, you know, we are childless, not by choice, but you know, I have a nephew and a niece, and are in school, and I sit there and wonder, how many times is it going to take when they get reinfected? Are they going to see something down the road, maybe even 10 years down the road, with all this? So trying to really get pediatricians to be on board, and to, I can't imagine how difficult that must have been, especially with the amount of doctor visits. So thank you for sharing. Thank you. Yes, please, next.
I have a comment and then a question as well. So first of all, people know me, that my child has had long COVID for the last almost 2.5 years. The first 13 months, there was significant gaslighting. Then we finally met the right clinician that actually really understood what he was going through and was able to actually provide the right support. But recently, we actually saw a new clinician that actually has a specialty in long COVID, and I'm not going to name any names. That individual did a reasonable job assessing the child, but when the report got sent back to the GP, on the report, I know there's absence of biomarkers, so because you can't have any confirmed diagnosis, it just said possible, like likelihood of long COVID, and it said possible. So the problem is the language that's being sent back to the clinicians when they're looking at the report leads to areas of doubt and confusion, and then what ends up happening is we go back down that gaslighting route. So this clinician, I brought my son in like last week to be assessed, and he actually said, well, I've seen this report, it only says possible, so maybe there's other factors that are contributing, which we know there aren't because he's been fully assessed. So I guess the question to the medical community is like, how are we 4 years into when the pandemic started, and likely 4 years into long COVID cases becoming part of a circulating disease burden, and there's still lingo from specialists that deal with long COVID that leave doubt in the minds of clinicians and the GP.
Thank you. I don't know if there is a clinician who wants to try to answer that here. I mean, I think I do agree that, you know, not just from my standpoint as a patient, I'm, you know, very good at trying to make sure that what gets put in my files is what I say, but that's not easy if you're a kid, I can only imagine. Yes, Angela, June.
Thank you for that comment. This is something that we definitely need to do better. You know, I have trainees working with me, and so when I see the letter that waffle a bit, I sort of said, you know what, this is a clinical diagnosis, just as similar to diagnosing migraines. So you gotta have clear diagnosis. But again, it has to do with comfort level of different clinicians. And those who see more will be more comfortable, and those who see less is less comfortable. And so, you know, that's partly why we are doing this ECHO program, to try to engage clinicians so that they will feel, you know, it's okay to ask questions, that no question is stupid or ignorant. And we want a safe space for clinicians to come and ask their questions and develop sort of a community of practice. So I would encourage that you spread the word as well, that these ECHO programs are coming in the next few months. And so, you know, it is really based on a lot of different work from all through our network. And we do see a need for that. Thank you.
Thank you, Dr. Chun. Yes, it looks like we're just about ready to be tied up. So, yeah, 1 minute.
No, I was just going to say,
Yeah, I think I can turn this on.
thank you. Yeah, so just as another clinician, to answer that question, thank you so much for bringing up the question about definitions and labels. I didn't get a chance to answer the earlier question that also came up in Lori's talk about the labels and things like that. So I want to let sort of the community here know that this was identified as one of the priorities from Long COVID Web to help ratify an appropriate definition for long COVID that is going to be usable for the patients, usable for clinicians, usable for researchers, such that when we communicate, we're very clear, and that comes down to also the definition. How do you define somebody in this era, without biomarkers? So that is work that has started and will continue on. This is going to be a project that involves patients, clinicians, researchers, and this will review the definitions that have been used worldwide. This is not to say that we're not using long COVID as a term anymore. That will always be the broad umbrella inclusive term. But there might be situations when people or clinicians or researchers want to specifically look at patients that are post-infection a certain time of days or weeks to see if their treatment's going to be appropriate for them. Or how do we stratify or prognosticate their future risk of going into long COVID if they have symptoms at 4 weeks. So it's just a recognition that right now there are limitations with the definition, and Long COVID Web has heard this from the patient community, that there is a lot of confusion and, there are challenges to the labels that are out there, and there's a lot of inconsistency. So that is a project that is being looked at, and hopefully in the next few years, we'll be able to come up with something that is reflective and consistent for the patient community, for researchers, clinicians, in a way that's inclusive and equitable and doesn't leave anybody in the cold. And so with initiatives like that, hopefully that will make it easier for practitioners to use that label. Of course, there are other guideline efforts that Angela alluded to, so that hopefully will also help practitioners and give them sort of that comfort in making the diagnosis.
Well, thank you for that. Thank you for all the information. I was going to say, is there a couple more comments that maybe we can throw in? And that would be lovely if we could do that. You notice, Susan?
Yeah, I'll add one. It's my young adult son, age 21, was just told by his post-secondary school that maybe he shouldn't be in school right now. He's asking for 1 class per day, or if not possible, notes or recording from a class that he can't attend. It hurts to watch him navigate this world. How would it be good for him to lay about at home all day? Do they know how hard he's working to take these courses? So I'm seeing other comments where it just seems to me it's more about the whole village, not just about particular sectors that are, the healthcare professionals and other groups. It's education, it's the legal profession, it's insurance and all the other aspects where there needs to be more sort of a coming together and more perhaps kind of contact sports around the educational side. And we heard earlier from Kara, right, about some, direct advocacy work from parents to schools. So it seems that there is more work to be done for sure.
Yeah, and I think, I was first trained as a sociologist, so I always look at things like 10,000 feet up in the sky and look at it that way. And, all this sort of strikes me and when say, how do you advocate? How do you change? How do you do things? And, I in my research project management, I was in the area with marginalized people. And I was in a meeting that I never kind of forgot. And I was in a meeting with a health economist, PhD, who said, well, unfortunately, if you put a price tag on it, at least that gives you a step into changing social policy. So I think that maybe we've already heard about it earlier today, to just start to get that economic data in on the on what how much it's costing people for long COVID, taxpayers and everything else, because of lost hours, of lost work, of on and on and on, when they continue on saying that, you know, certain things are, you know, we can't find people who work, or we can't do this. Well, they don't want to say it's COVID because you don't want to do that. So, but the financial impact has more sway to this particular person, I remember, in terms of policy at the political level, sometimes than having, sad enough, but having, you know, sorry, sad stories being told. So, yeah, thank you. I guess we're going to be tying up pretty quickly here. So I just want to add a little bit, because Dr. Truna actually talked a little bit about this, about the resources on the long COVID web. And I want to reiterate for everyone to please check that out, because the Patient Advisory Council, we had a subcommittee on that, and they spent a lot of time with the clinicians and other people to put those trusted resources. So there was a lot of work that went into that. So please do that, okay? So that would be very, very important for everyone, and send it out, put it on Facebook and everything else, so that other people have some resources too as well. So also what I want to sort of note as well for today is that everyone that's sort of put everything on the chat, we're going to collect those comments, okay? Because we didn't read everything out, but we wanted to document as much as we could. And we have some ideas of just sort of trying to put it together in a word art share to share. So, so hopefully we have lots there. And I probably found some that's maybe in other chats, but that I may have to ask for permission to put. So, because there was some really amazing stuff that was just outside of this as well. So, of this session in terms of comments. So, that's good. I think, is anyone else? No? I think we're coming close to the end of the day, end of my spoons, end of my energy, as well as a lot of other people. I just want to thank everyone for coming out. And I hope that we can do this again, much more of a free feel sort of session where we're not really sure which way it's going to go. So it's been very interesting to try this out. So, and I just want to say thank you again to all the people that did the artwork. I can say it definitely made me quite emotional to see and read those pieces. So I really appreciate that, because there was a lot of people who used words that said something that I couldn't describe. So I really, really do appreciate all that. And take care for all the caregivers and the long COVID experienced people. And thank you for coming, and have a tolerable day. Thank you.